Good afternoon, and thank you for joining us today in this image challenge live stream event from Retinal Physician. My name is Marianeli Rodriguez. I'm a retinal specialist with Vitreoretinal Associates, and I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image each month and then discuss the diagnosis and management using this platform. We'd love to hear your thoughts online, and you can find us in Facebook, LinkedIn, YouTube, and Twitter. And they're also welcome to write on the chat and share your thoughts with us during this event. And today I'm joined by Kareem Moussa, who is a retina and uveitis specialist at UC Davis. And I know Kareem from my fellowship at Massa and I love always catching up with him. Kareem, welcome.
Thank you so much, Mari. It's a pleasure to be here with you.
Yeah, I'm so excited to talk to you about uveitis.
Me too, our favorite topic.
Yes. So I want this to be a dynamic discussion, and I want to pick your brain on a management of a not so uncommon posterior uveitis case.
Sure.
And probably all retina specialists out there have seen a case like this at some point in their practice. So this is a 38-year-old female that presented to our clinic with splotchy vision and photopsias in the left eye. Her vision was 20/20. She had normal intraocular pressures. On slit lamp examination, she had a healthy LASIK flap. She had normal anterior segment otherwise, normal. The AC was deep and quiet. There were no cells. She had like very, very trace NS, and there were no cells in the anterior vitreous. And then when we did a dilated exam, we noticed that there were this very subtle white dots in the periphery, more prominently seen in the nasal side. And there was also some granularity to the fovea reflex. And when we did a fundus autofluorescence, this dots appear a little bit more prominent, and there were hyper autofluorescence. And OCT, we noticed that there was an area where there was like some focally disruption of the outer retina. And on further history, she said that she had recovered from a recent illness, and she also had a history of a chronic inflammatory demyelinating polyneuropathy when she was younger, and she was treated with steroids and IVIG, but her last treatment was in the year 2000, so like 20 years ago, and she's been healthy otherwise. So now, Kareem, with this kind of thing in mind, I want to kind of, tell me what a uveitis specialist thinks when they see something like this, what kind of questions they want to ask, what's your differential
Yeah,
diagnosis?
sure thing, Mari. So, you've already given me a great deal of information that's very useful. For these patients, I always think it's a great idea to try to get a good history. And you've already mentioned to me that she is recovering from a recent illness. So I'm assuming that this patient recently had some sort of viral illness. Is that what you're implying?
Yeah.
Okay, good. So I think that's always a important question to ask when we're seeing our patients is how are you doing systemically? Because sometimes we have systemic diseases that can have ocular manifestations, and getting that history of a recent illness can help guide us towards the correct diagnosis. Now, similarly, this patient already has a autoimmune disease history. You mentioned earlier that she has some sort of demyelinating disease or a history of it in the past.
Mhm.
And we know that if you have one autoimmune disease, you're at risk of developing other autoimmune diseases as well. So those are key components of the history that I think are important to ask in our patients with uveitis. How's your systemic health? What other medical conditions do you have? After obtaining the history, we need to perform a good exam. You've described some key features for me that will help me in my assessment. With these patients, I like to get a good anterior chamber exam before I look in the back, and preferably I like to see the anterior chamber before they're dilated. The reason I like to do that, I know it's not always possible in retina clinic, but the reason I like to do that is when you dilate the pupil, you will often get some release of pigment. You will sometimes also develop some white blood cells just from dilation. So I want to know, is the anterior chamber involved or not? Because if this is a pan-uveitis, for example, then my differential diagnosis would be different compared to a case of posterior uveitis. So I like to know which anatomical compartments are involved. When you examine the vitreous, this can sometimes be a little hard, but you can sometimes have a few cells in the vitreous that would not be visible to you unless you have the patient kind of look up, down, left, and right to get the vitreous to move around a bit. So when I'm looking at vitreous cells, I always ask the patient to look up, down, and then at my ear. That will give the vitreous a chance to jiggle, and you'll see cells there that you may not be able to see otherwise. And knowing if a patient has vitritis or not also influences my differential. You've described to me what you see in the fundus. You see these sort of ill-defined, kind of white-looking lesions. And after I do a good exam, I will then want to do a workup. For any patient that you're seeing in the retina clinic who has uveitis, you need to order at least two things, preferably three. Syphilis, we know it's the great masquerader. We also want to order tuberculosis testing. And we want to consider sarcoidosis as well. And I think a chest x-ray is a good screening test for that. So that's generally how I approach my retina patients who have uveitis. And after I get this workup, after I get this imaging, I then make an assessment and go with the plan from there.
Oh, interesting. I remember those three tests and I always order them. And I have seen a good amount of syphilis that would have flown under the radar.
Hmm.
Um I seen very, very little sarcoid. I've never seen TB.
Yeah.
But for sarcoid, I usually order an ACE level. I don't order a chest X-ray. So why?
Yeah.
Tell me why a chest X-ray?
So a lot of people will order ACE and lysozyme as screening tests for sarcoid, and it's not incorrect. A lot of people do this, but the sensitivity and specificity of these tests for diagnosing sarcoid are actually pretty low. Have you ever had a case where you made the diagnosis of sarcoid based on ACE or lysozyme?
No, no, no. So this patient actually had a CT.
Yeah, that's been my experience too. I used to order ACE and lysozyme, and then I learned later that they're actually not that useful to me. So I think the chest X-ray is a better screening test. If you can get a chest CT, if you really think someone has sarcoid, if they have characteristic features of it, I think a chest CT is even better. But sometimes it's a little bit harder to convince insurance to pay for a chest CT as the initial test. So while getting an ACE and a lysozyme is not incorrect, a lot of people do it. Uh, my preference is to get a chest X-ray. I think for me, it's a better screening test.
Oh, that's great. I guess I'll put that in my. Um, so I guess like the other question is, I ordered these tests for the
Mhm.
patient. Everything was negative, and I actually every time I see a uveitis patient, I just send it to Massayaneer because don't have too much of follow up for these patients. And
Right.
least I say go there, get checked, and then I can follow you
Mhm.
later on once you're stable, just more because I don't want to miss anything that is
Right.
obvious, and I don't see these patients in my clinic that often, so
Mhm.
that's why I do that. So I guess as a uveitis specialist, I'm sure you get a lot of referrals from like retina specialists and probably also general ophthalmology. So
Mhm.
what constitutes an inappropriate consult? When am I sending too much to Kareem's clinic and he's like, oh, can't believe Mari's sending me another patient?
I think it's never inappropriate to ask for help when you feel like you need it. Uveitis can be a blinding condition if it's not appropriately treated. So I think if there's a case that you are uncertain of, then it is certainly worthy of getting a referral and getting an expert opinion on these cases. I would always agree with you on that.
Okay, great. That makes me feel better.
Yeah.
So then I guess this white dot syndrome, sometimes they when they saw this patient at Massayaneer, already the dots were kind of disappearing, and
Hmm.
they were mostly gone by the time they saw it. And we shared our imaging with them, and they're like, okay, she's better. And then we've been following her. She's improved.
Good.
So how do you think about these patients in terms, once the workup is negative and things like that? How do you follow them, and when do you put them in one category versus another? Can you just do a 1 or 2 minute summary of your favorite imaging modalities and how you would
Mm.
separate the various white dot syndromes? Crash course here.
Yes, yes. So I like to get angiography on all of my patients who have posterior segment involvement. I think it's useful for not just diagnostic purposes, but also in terms of management. It's a test that can be repeated in the future to help me see if the inflammation is getting better or worse, if things are changing or not. So that would include both fluorescein angiography and ICG. ICG is great for looking at the choroid. The FA can sometimes show you changes in the choroid, but ICG will show you disease in the choroid much better. And you will sometimes be surprised at how much you can see on ICG that you are unable to notice on the FA or on your clinical exam. So I think both FA and ICG are useful. I tend to get these for, I think, almost every patient of mine who has posterior segment inflammation. Now, in terms of, which bucket do we put this in, this white dot syndrome? Is this AMPI? Is this MUDES? All these other diagnoses that we put together and lump them as a white dot syndrome. I try not to actually put these patients in different buckets because I think ultimately what we want to determine when you see these patients is, do you have an infection or do you not have an infection? If you have an infection, we have to treat the infection, right? If you don't have an infection, then we either leave this alone if we think that it's going to get better on its own, or we treat you with steroids or some sort of immunosuppression. So you will often see people have debates on whether a case is, for example, multifocal choroiditis or PIC, because sometimes these two can look quite similar. And one expert might say this is multifocal choroiditis, and another expert might say this is PIC. But practically speaking, does it make a difference in terms of how you are going to manage these patients? Probably not. You're still going to potentially immunosuppress them. You're still going to look out for CNV. It doesn't really change your management much. So I try not to stress too much about labeling this case as a certain diagnosis within the white dot syndrome bucket. Instead, it's important for me to recognize that something is going on because, Mara, you're an excellent retina specialist, but let's say you didn't do a good exam, or you didn't get this autofluorescence, or you didn't look carefully at the OCT to notice that abnormality. You could easily miss these findings, right? These are very subtle findings. So I think the key thing is to do a good exam, recognize that this patient does have an inflammatory disorder, get your workup, and if there's an infection, treat it. If there's not an infection, you're either going to watch it or immunosuppress them. Whether you call this MUDES or multifocal choroiditis or any other diagnosis within that white dot syndrome bucket, I think is less important.
Wow, Kareem, you blow my mind like always. It's such a great conversation with you. I feel like we could talk about it for like
We could.
now. Great. I've learned so much. Thank you so much
Oh,
for
thanks, Mari.
your
No, I always enjoy speaking with you.
Yes, and thank you everybody for tuning in today. You can leave your comments online and join us via multiple platforms. We hope to see you again in about a month, and we'll discuss another interesting case, and hopefully we'll have Kareem again at some other point.
Thank you so much, Mari.
Thanks.